They come right too, but this patient didn't, and he was also very sweaty, and the room was pretty cold. And so we transported because obviously we can't leave him with altered mental status, and it ended up he was being hypothermic just being in a room sweaty that was cold. So we had like two issues going on at once. I'm just saying for like assessment parts and just making sure like if one doesn't correct, keep looking. So we're gonna check our ABCs. Make sure the airway's clear. And again, like humidified oxygen helps. This is one time I actually would agree with that for humidified oxygen because you're gonna keep like put in warm, moist air, and like if they're out in the cold, like you know how dry that gets, and so their lungs aren't going to be the best either. So humidified oxygen would help if you have it available. Circulation.
You guys have that on. You guys have that on most ambulances.
We don't in Berlin now, but we could grab it. Like if we do it on transfers or whatever, we've used it.
Yeah.
But we don't carry it necessarily. So we're gonna check for carotid pulse. Wait up to 60 seconds. So you can show this to Kevin. This slide. Reference it.
I think it may have something to do with it talks about respirations. And I was assuming this. So I got to go back and really look into it.
So AHA recommends that CPR be started to know detectable pulse or breathing. So yeah, we're more than likely, depending on what level they are, we're going to be starting CPR on these people.
Unless you get to them and they're so frozen that like you just can't press their chest right now. There's a certain time that you can't do it.
Sure. Yeah, if they're an ice block. Yeah. But I got a couple more calls. Like, I just want to I don't do one of the calls isn't in mind. I'm just aware of it. Errol responded to somebody who was out overnight. I think he had a hip fracture. Nobody found him until the next day, and it was really cold. And his body temperature was, I have no idea. It was in the low 90s. And they transported him. They didn't do CPR though, but he survived remarkably. But we also, when I was on this call, responded to somebody who went into the river. You know what Ambagog is, right? Yes, you do.
Yep, Lake Ambagog. Yep.
Well, not Ambagog, Androscoggin River.
Yep. Oh, yeah.
So somebody drove into that river. I think they were drunk. And we did CPR. And we did transport doing CPR. And I was on the call I didn't have my medic tools. Not that I could have done anything different, but this guy, he was messed up. But we had a pulse. We gained a pulse back doing CPR. But we transported to the ER, and I don't even know how long they did CPR for. Like they called another agency to use their Lucas because they couldn't call him until he was like warm and dead. Yeah. But he ended up dying. So yeah, if like they're not a block device, we're gonna do CPR because we never know until they're warm and dead. So investigate the chief complaint, obtain medical history, be alert for injury-specific signs and symptoms, and again, pertinent negatives. Find out how long for your sample history, like how long he's been exposed, what temperatures and all the good stuff in different body parts that were exposed. So for the physical examination, focus on the severity of hypothermia. Assess the areas body directly affected to the cold exposure, like I said before. Assess the degree of extent of damage. So that's more for probably local issues, like the hands and feet. Some vital signs will be altered depending on their severity. Respirations will be slow or shallow. Pulse will probably be low, was slow, and not very good blood pressure. And there's going to be mental status changes as well, depending on the severity. Where you can do a body temperature, and like our rigs are required by state to have a hypothermic thermometer. And I wouldn't even bother putting a pulse ox on a patient like this. They're not, because like, again, like what does the pulse ox read? The hemoglobin. Yeah. So they're not going to have any circulation to their fingers or so it's not going to get a good reading. And everybody would be freaking out because it's like 60. So like we're going to reassess every 5 minutes, like from head to toe, and keep. Yeah, rewarming can lead to cardiac dysrhythmia. So that's when the thick cold blood gets pumped into the heart, and it just messes everything up even further. And again, on the handoff, just talk about what you did to the receiving facility.
Kevin said, put them on ETCO2 waveform.
Oh, I knew that was coming. Yep, capnography. Because it will show how what their CO2 level is.
He's going over that tomorrow night, right? Isn't that?
Yeah.
Yes.
Yeah, I'm doing that class tomorrow night for another department, but I invited the EMT class for it.
So again, we're gonna like actively warm these patients. Place dry, warm blankets over them. Like I do the warm packs. Yeah, remove any wet clothing or cold clothing. Like yeah, do what you can to warm them back up. Again, the humidified oxygen, warm humidified oxygen even. But do not massage the extremities. Do not allow the patient to eat or use any stimulants because that will cause dysrhythmias, and he or she might go to surgery, and that would be bad. So yep, apply heat paddle packs to hot water bottles, the groin, axillary, and cervical regions. Give warm fluids by mouth. Oh, Jason's typing. You're typing.
Sorry, I was gonna type something to Kevin. I'll do it on a message.
Oh no! I didn't know if you wanted to talk in the class. Sorry, I didn't mean to cause attention.
No, it's right. Go ahead.
So I'd like the mild for moderate. We do not actively rewarm patients, but we want to stop the further heat loss. So we want to remove them from the cold environment. We want to treat them very, very gently. And we want to remove the wet clothing and cover them. But that's like when we'll get the dysrhythmias if we put the hot packs and stuff. Remove the patient from further exposure to the cold. Remove any wet, restricted clothing. Handle injured part gently. Rhabdomyolysis.
Yeah.
That's muscle tissue breakdown that does kidney damage.
So I threw that in there. I wanted to do it a little bit earlier, but I'm on the road driving right now. So I added that to it because he was talking about the hypothermia and having a patient on the floor, fractured hip, core temp of let's say low 90s, do a rectal temp, they find like 92. We don't just look at the fact that they're cold. We also need to look at other things as well. And rhabdomyolysis is another thing too for a patient that's been on the ground for a long period of time. And it releases myoglobin, okay, and proteins, like a myoglobin being a protein. that gets released into the system, causing the patient to have their kidneys shut down, which then in turn will put them on maybe an acute kidney failure going into dialysis. So I want people to think that there's other things wrong with patients on the floor. Like you find grandma trip and fall, environmental. Granted, it might be 70 degrees outside. They're on the floor and it pulls that heat out of them, right? That cold pulls that heat out, causing them to become hypothermic. We get there like, oh, fractured hip, let's treat them, transport them to the hospital. Oh, they're a little cold, put a blanket on them, right? So you check a tympanic temp and it's like 96, 97. Their body temp being 92, being on the floor for a long period of time, can put a patient in the rhabdomyolysis. Okay, so I wanted you guys to have an idea of that. If you want to look more of it up, you can. Or Morgan can probably go more in detail later on in another lecture with it. But I just want you guys to be familiar with that as well, because it's not, and a patient is hypothermic, that's not all you're going to see. Okay, they could have other things going on as well. I just want you guys to be aware of it. That's all.
Okay.
That's all I had, Morgan. Sorry, I didn't mean to interrupt.
No, you're fine. So we're on treating local cold injuries. So that's like just the hands and feet, or like something that's specific in the body. It says like for immersion foot or the trench foot, remove the wet shoes and boots. I'm surprised my kids don't get that. Now that I think about it, because feet are always wet. So frost up, like, just bring them in a warm area, but never like massage or rub injuries, because you don't want to cause more damage. And if they're like have the blisters, we do not pop blisters. Immerse the frostbitten injuries into 102 to 104 water. So that's like above lukewarm water. Put sterile dressings over them, because you don't want to be infection, and they're going to leak. And if they're going to be any chance of freezing, don't warm them back up. If you're at risk of hypothermia and work in a cold environment in the north or middle state of New Hampshire, survival training, precautionary tips, wear appropriate clothing. Like I never do. Any questions about cold exposures? No.
I don't think so.
So heat exposure is kind of the opposite. Instead of the body trying to, and they're both pretty tricky to treat. So instead of like the body constricting the vessels to bring it to the core, it kind of dilates it to get the blood flowing out. Because like the more surface area that blood can get to, the more heat that it can dissipate. So like a lot of heat gets dissipated from the head, especially mine. No cover. So a lot of heat usually does get. Oh, Kevin's also putting in our protocols. There is a lot of information on there.
And like Morgan said, there's a ton of information on there for the New Hampshire protocol for hypothermia. Maine is very similar, but the thing I want you guys to be extra familiar with is the second one I showed you on the green form. And those are the different stages of hypothermia and what needs to happen. And if you look at stage 4 hypothermia, one of the things listed on there is if the patient has hypothermia within a certain body temperature, they want you transporting, if you're within an hour, to a facility that has ECMO. And the closest facility to the Ospey Valley that has ECMO is going to be Portsmouth Hospital. The other one is Dartmouth. Maine Med has it for Portland, for Maine as well. But other than that, nobody else in Maine really has it in the southern Maine area. So kind of give you guys an update on how that works. If you have a patient that requires ECMO that's hypothermic like that, Portsmouth and Dartmouth are the only two in New Hampshire that have it.
Same with hyperbaric chambers. Oh, is Kim talking or somebody?
I'm not sure.
Is ECMO stand for extracorporeal membrane oxidation?
So basically, they take blood out of the body, they oxygenate it in a
Yeah.
system, and they put it back.
That's what it is. Yep. I found it on
So
Google.
they use it for bypass surgeries.
Exactly.
Correct.
Yep.
And
Warm
like
it
that, according to the protocols, the only two that do have that are Portsmouth and Dartmouth. But yeah, it's actually kind of cool how ECMO actually works. And if you go out like in the mid country, they actually have ECMO ambulances that show up with an ECMO unit to the scene.
That's crazy.
Yes, they're big ambulances that show up. Like they're triaxle ambulances.
Yeah.
So,
That
all right.
fools.
That's what it looks like. You just brought up. So, yeah, I just wanted you guys to be aware of that as well. So those are the New Hampshire protocols for the EMT level. I didn't put advanced and paramedic because honestly, there's not much more that we're going to do. 90% of the treatment for hypothermia is going to be at the basic level.
Okay.
Right. So heat exposure. So our body is going to try to dissipate that, and then also with sweating and evaporation of the sweat, so it can dissipate more heat. So risk factors again are high air temperatures, high humidity. Like I don't know about everybody else, but when it gets high humidity, high temperature, I sweat like nobody else's business.
Yep.
Vigorous exercise. What was I doing? Oh, building a house, and I started getting dizzy. Like this house I helped build. I think it was that, but I did get dizzy, and I had to go sit down for a little bit. I don't want to be that guy. So persons with greatest risk again are children because they're just can't compensate very well, and their master area, surface area, is large. Geriatric patients because they don't have capabilities for managing their bodies out. Patients with limited mobility because they can't get out of the heat very well. Or people like older people who live like assisted living don't have AC units or whatever, or ways to cool down. Patients with heart disease, COPD, diabetes, dehydration, and obesity, like our chronic everyday people like me. So what happens? Like heat cramps, our electrolytes get off. And, whoa.
What?
That wasn't me.
Sorry.
Don't be sorry. It lightened us up.
Sorry.
So like heat cramps is like one of the first stages of like a heat emergency. It's not an emergency, but it feels like it. Vigorous exercise, especially with people who become dehydrated. It happens to me every summer at camp because A, I like beer. B, we like play a lot of like kind of like washers. It's kind of like the sandbag game there,
Cornhole, yeah. It's cornhole.
cornhole. But it's
That's
kind of like that.
washers.
So I'm up and down, and I'm always dehydrated. And every night, every time, I will get wicked bad cramps in my legs because it's from dehydration and just working muscles I'm not used to. And it doesn't always occur when it's hot outdoors because I'm doing it to myself. And it's usually not hot. Exact cause is not well understood. Well, it's working muscles that you're not used to, electrolyte imbalance and dehydration and other causes. And it usually occurs in leg or abdominal muscles, correct. Well, the first time my daughter had a cramp once and she didn't know what it was. Poor thing.
Leg cramps are painful.
Yeah, they are.
They can be very painful.
So heat exhaustion. It's just moving on from the cramps. It's like more severe. Hypovolemia. Remember when we take the fluid out of the tank? One of the shocks. That's pretty much what path we're going down. Usually high humidity, dehydration, and exertion. And poorly, like there's sweating and there's no way to just get cool air, cool off. excuse me. So signs and symptoms: dizziness, because again, it's that kind of shock. It is kind of a shock. Weakness or syncope. People pass out. Nausea, vomiting, headache, cold, clammy skin, ashen pallor, dry tongue. Like every time somebody thinks that they're dehydrated or whatever, or just in general, I always like look at their mouth anyways. But if they're like dizzy or whatever, have them look in their mouth and like stick out their tongue to see if it's like dry or cracked, if it's their saliva or whatever. So that shows if there's dry mucosal oral mucosal membrane. And another one, and I'm sure it'll pop up. They're usually normal vital signs, and could be having an elevated body temperature because the body's still compensating. These common. Okay, they didn't put it in here yet. So another sign that for heat exhaustion with dehydration or whatever, it's called skin turgor, and it was in the book. Like if you like pull up on their skin, on their like the back of their hand, and if it stays up for a while, like because it's kind of doing it to me right now, if it stays up for a while, it means they're dehydrated.
It's like tenting, right? Skin tenting.
Yeah, tenting. Right. So ever go to a nursing home and just like pull up their skin, they're all dehydrated.
They're all
I am too right now.
dehydrated.
See, like how mine's not really going down very quickly. I need to drink more. So then moving on from the heat exhaustion is heat stroke. And it usually bodies can compensate very well until they get to heat stroke. And it happens when the body just cannot maintain anymore. The gas, there's like no more fluid to cool it off. The body's just overwhelmed. It's shutting down. Usually people become altered and they pass out, become lethargic and pass out. During vigorous physical activity, and it can be anywhere. If you're not like staying hydrated, it will happen. Clothes are poorly ventilated, humid, heat waves. Like I don't know if we went to a lot this year, but like we had a rough summer. It was like hot for a while, or was it raining? It was both.
It was so humid.
Children who are naughty, and so you leave them in the car on a hot day. No, that's not true. We don't ever do that. But people do forget their kids in the car, and then it happens, and it's unfortunate, and it's sad, and I can never imagine.
I don't know how you can do it, but whatever.
I don't either. Usually they're like yapping my ear off, and I could never forget.
We have a truck at work that reminds you to check the back seat. It's a Ford F-150. And I think you can shut it off, but it reminds you to check the back seat.
If you have to be reminded, you should not be allowed to have children.
Exactly.
Not you, I'm just saying in general.
Yeah.
I've driven down the road without putting my kid in a car seat once. I don't know if that's as bad. Then she popped up over the back of the seat, and I'm like, slammed on the brakes. I was on the phone with my wife, hands free, and I'm like, I gotta go. She's like, what's the matter? And I'm like, I'm not telling you right now. But I don't know how people ever leave their rigs. But another side note, like I had a Great Dane, and we were getting ready to go to camp, and we left her in the truck. The truck was black, the dog was black. But we left the truck running, the AC was on. But like every time that we left, the dog would like start barking because it had a separation anxiety. So we went and got it chicken tenders and like got food for the kids or whatever. We came out. Somebody was waiting next to our truck to give us shit for leaving the dog in the truck. It was a hot day too, but I'm like, whatever.
My dad leaves his dog in the truck with the AC running and country music on, and he has a little sign on his window that says, "The dog is jamming. He's nice and cool. Please don't break my windows."
That's funny. Anyways, moving on. Sorry to digress. No, don't be sorry. I'm the one that started it. I just thought it was funny. So signs and symptoms. They're going to be hot because they're not going to be able to compensate anymore. They're going to be dry. The mouth is going to be cracked and dry. The skin, there's flushed skin, that's when it's going to be red. Their body temperature is going to rise. They're going to be either agitated or they're going to start like being lethargic, depending on how far they are, and then unresponsive. And they could have seizures because their electrolytes are going to be off in the fluids. There's going to be a rapid, weak pulse. Again, same thing with the shock. Signs and symptoms of shock, basically. Increased respiration rate and cessation of perspiring. They're not going to be sweating. So I guess we're going to go to seed sign doses up. Again, pretty much what we did before. AL, seed safety, BSI. We're going to make sure like we're safe. We're going to be able to nice and cool. Because like if somebody's out in rural, wherever in the woods, we're going to get them out. We're going to make sure that we have fluid to replenish, like drinking water and whatever. Make sure we have gloves and eye protection. When we get to the patient, we're going to form a general impression. Sick or non-sick? Is it just like heat cramps, or are they downright almost next to death because of stroke? We're going to do a rapid scan. Avoid tunnel vision. That's easier said than done. And we're going to do the APU. Are you alert oriented, verbal, painful, so on and so forth. We're going to check for airway, make sure it's clear, whatever. There's nothing in their mouth, loose dentures, gum, whatever could be in there. And make sure they're, because people who are heat stroke or heat, they could be vomiting because of just this shock. We're going into shock again. And if they've any falls or mechanism of injury, we're going to consider spinal immobilization. And if unresponsive, we're going to do insert a properly sized oral airway or use bag mask ventilations. So this is talking about, this graph is moist, pale, cool skin, excessive fluid loss. And so basically it's the beginning of shock, fluid and salt loss, electrolytes. Hot, dry skin is the flush. And hot, moist skin, his body's unable to regulate. So they're just hot and they're still sweating. So like certain skin's something you can like look at while you're walking up to a patient. You just take it all in at once. We're going to investigate the chief complaint. Why are we there? How are we going to be able to fix it while we're there? We're going to look for this absent perspiration, decreased level of consciousness, confusion, muscle cramp, and nausea. So muscle cramping would be bad because that's just like beginning stages. And the nausea and vomiting. We want to make sure that airway stays clear. We're going to do the sample history, signs and symptoms, allergies, medications, pertinent past medical histories, because that affects how well they're going to do with the exposure. Last oral intake and events leading up to. Oh, diuretics. Does anybody know what a diuretic is? It's kind of important for exposures.
It makes you pee.
Yep, it makes you pee. It's Lasix.
Yeah.
So if they're going to be peeing, excessive fluids. Moving on. So we're going to just keep doing our reassess every 5 minutes. We're going to assess for muscle cramps or confusion. Examine a patient's mental status and vital signs. Pay attention to skin temperature. Turgor, there it is. Skin turgor. And level of moisture. And we're always going to do neurological examinations. Like you just talk to your patients, and then sometimes they can fool you, but usually you're going to know. Vital signs. Vital with hyperthermic are going to be tachycardic and tachypnic. Like it's the beginning stages of shock. So just always think of hypovolemic shock. So falling blood pressures, again, is going into shock, decompensated shock, actually. In heat exhaustion, skin temperature may be normal or cool and clammy. Heat stroke, the skin is hot. So I'm sure this is going to pop up on a quiz somehow, somewhere, the two differences of those. Heat stroke, the skin is hot and usually without perspiration. And heat exhaustion, the skin temperature may be normal or cool and clammy. Diaphoretic, like the beginning of stages of shock. Reassessment, watch for deterioration. So whatever, you make sure that you're going to be able to, what you're doing is working. And if they're still deteriorating, how are you going to be able to change up what you're doing to fix it? Monitor vital signs every 5 minutes. Evaluate for interventions, and be careful not to overcool a patient, which is important. So we, like, again, with the hypothermia, like with hyperthermia, we can put cold packs on like their trunks, like on their necks, their armpits, and their groin area. And this is one that you can call for ALS for. Not that we're going to be able to do anything directly, but if they start shivering, we can take care of that. Why would shivering be bad in a hyperthermic patient?
Well, because if they're hypothermic, they're already cold. Shivering helps. It lowers the
Hyperthermic.
body.
Hyperthermic.
Oh, I think it's hype. Then I don't know. Thought I had.
So, like, if a patient is hyperthermic, like above their body temperature's up, but we want to cool it down, right? So we're gonna like put cold packs or whatever. We're gonna strip off what clothes we can. We're gonna lower the, like, put on the AC or whatever. But if we get them too cold and we start shivering, they're gonna start overheating again.
Got it.
So that's something that you should consider if you ever deal with it and have ALS. And again, talk to the receiving hospital for what you see, saw, anything that is important for their continuing health. Any questions about that?
No.
So I guess this is going over management of heat emergencies. Remove the patient from a hot environment, of course. Again, like any clothing that you can get rid of, do it. Because you want to start cooling them off. Rest the cramps. Like what I have to do, like I have to stretch and walk in order to get it out. If your ambulance does have fluids, you apparently, and follow your local protocol, you could give them PO water, like cool water or whatever. You can, you know the things that like at Santa's Village or whatever, where they have the mists through the fans and stuff. You can do that to them. Same thing with heat stroke. Move that of set air conditioning cool. Remove the patient's clothing. Administer high flow oxygen if it's indicated. And if they're like altered and they're having dyspnea or tachypneic, not tachypneic, slow breathing, you can ventilate. Aggressively fan the patient causes altered mental status. Check for blood glucose because you never know if they're have hypoglycemia or not. And if they're working to cool off, that could cause issues. Oh, there it is. Call for ALS for begins of shivers. And I bet that shows up on a quiz too. So drowning. Any questions without heat?
I don't think so.
It's a lot, I know. So drowning is respiratory impairment from submersion of a liquid or immersion of a liquid. Like it doesn't take much for somebody to drown. Like only that much water in a bucket of, like a 5-gallon pail bucket. And like I think when our first practical or our first Sunday, Luke Scott was talking about a call he was on with a 3-year-old.
Oh yes, the 3-year-old.
Yep. It happens. So, and that's like one of those things under the age of 40, usually trauma or causes of death are done by accidental. And there was another statistic in the book, and I can't remember what it was offhand. Like what percentages of deaths are from drowning, in particular. Risk factors are people who go swimming who've consumed alcohol. Not that I've done that. Pre-existing seizure disorder. So that's something like Devin's doctors talked to her about because she likes to go kayaking, and we live on a lake. So they told her, like, if she's ever out on a boat, she has to wear a life preserver. Unsupervised access to water. Patients with cardiovascular disease, because you could be swimming and have a heart attack or whatever. Laryngeal spasms can cause, like, if you inhale water or whatever, like, our vocal cords are pretty sensitive, and so they could spasm and shut everything off. So they talked about a lot about submersion, like people who jump in shallow water and have spinal cord injuries. Jason, do you ever have to deal with that in the Army at all?
No.
No. So yeah, people who jump in shallow areas and have spinal cord injuries, like they don't want to move anyways because their necks are going to be messed up or their backs, or if there's like paralysis, they're not going to be able to tread water or whatever, they'll end up drowning. Yeah, so most spinal injuries, diving incidents affect cervical spine. Stabilize suspected injury while the patient is in the water. So, this is definitely going to show up on a quiz. I've had it a few times myself. This is one of the times, like, if they're going to show, like, we protect the airway, we give 9 high flow O2, take inline stabilization. Yeah. So always, if there's any indication of like a submersion injury or cervical spine injury in water, stabilize the neck and then go to airway.
Yeah, it's on. Well, it's in the book. It's 1221.
Right.
Talks about that.
A few years ago, I went to somebody who, like, teenage kid who went to his buddy actually was at his house on a lake, and like the first thing he did was like run off the dock and into the water, and like it was a pretty dry season that year. It was he had head first right into the ground, and he had his C4 C5 fracture. So this is ways of rescuing people who have possibly drowning, like throwing ropes or reaching with a stick, or maybe she's pushing him with a stick, or throwing a floaty, rowing, and then going to get it with a towel. That's probably going to show up somewhere just because. If patient's not floating or visible in the water, organized rescue effort. That's when you're going to call in a dive team. I don't know if the state police do, but our like Fish and Game, like they have a whole crew that would go in and get it. Are any of you familiar with Pittsburgh at all? New Hampshire. So there's like a series. So there's a series of lakes, like first, second, and third.
Yeah.
Third lake, you can pretty much throw a stone across, but it's very deep. Like as soon as you walk off, it's 20, 30 feet, I guess. And people have like just driven off into there just for suicide. Yeah. And they had to go call a dive team, and it's really difficult to get people out. This made me think of it. Never given for resuscitation in a cold water drowning victim, hypothermia. So, like I said about the guy who drove off into the river Androscoggin, like we didn't give up, and it was tense. It was a tough call, but we did get his rhythm back. But in the end, he ended up dying. So the diving reflex is kind of like when you're in cold water, your heart rate slows up, and your breathing kind of slows up too, because like your body is trying to conserve oxygen for your core, I guess. And like cold water, it's just everything will shunt and close down, slow up. Any questions about drowning?
So another name for that would be called the mammalian diving reflex.
I knew there was a term for it. I just couldn't think of it.
Yeah. So basically, it's Mother Nature's way of shutting your body down, putting you in a bradycardic rhythm to keep you alive.
Yep. Thank you, Kevin.
Yep.
I knew there was a term. I may use that on Scrabble someday.
If you take my water rescue class ever, we go into drowning and diving injuries in detail.
I bet. So descent emergencies. So this is, I guess, like scuba diving and stuff like that. I've never done it. Never wanted to. Actually, kind of did. It would be neat, but so if you ever move on in your career of EMS, I bet Kevin knows a lot about like pressure, and oxygen levels and what it does to the body. And if anybody's been on the plane and like the ear popping or just feeling like you're in a bowl, it's because of pressure.
Just keep in mind that you are in a pressurized cabin, so it makes it a little bit different too.
Yeah. Lungs, like, because your air, there's pressure on your lungs always, but like if you go in water 10, 20 feet, there's going to be increased pressure on your lungs. So in all that area in the water, and the pain forces the diver to return to the surface, equalize the pressure, and the problem clears by itself. So perforated tympanic membrane or swimmer's ear. I've had this happen to me, but it was not from swimming, it was ear infection. So the water will get into the ear and it'll burst. And then like the middle ear is what helps people with their balance, the semicircular canals. If people who get to the rise to the top surface without breathing or whatever, or too fast, they'll get what's called a bends, or air embolisms, and they have to go to, again, Portsmouth or Dartmouth. I'm sure Portland has one too, for hyperbaric chamber. Right, I'm sure it's going to come up here in a minute. So emergencies at the bottom, inadequate oxygen and carbon dioxide mixture, so they're going to be breathing more carbon dioxide, but their body's not going to really realize what's going on. Accidentally feeding poisonous carbon monoxide into a breathing apparatus. So like the body cannot differentiate between oxygen and carbon monoxide, so they would not even know that they're dying. And there you go.
Yeah, you see that on divers if they have like one of those machine, right? Is that what you're talking about? Like on the Bering Sea Gold, they go underneath the ice and they have that tube that they're hooked to, and the air from the motor actually goes in through their
maybe
hose.
Yeah,
that might be what they're talking about.
Probably
carbon monoxide. Yeah.
Kevin just posted like the DAN network, Divers Alert Network.
So it's a Florida-based system that you can contact if you have diving emergencies, for them to assist you in treatment.
Oh, that's good to know.
Is it kind of like poison control?
Yes, I just don't remember the number. If you look it up, I can't remember the number off the top of my head, but it is available to anybody.
I'll have to get it. Maybe. I got it.
I got
it. Take too much time. You do. There you go. We're gonna keep going on this because we got only a few minutes left. So ascent emergencies usually require aggressive resuscitation. Air embolisms, there you go. So like air in our lungs will permeate out of our lungs into our bloodstream and cause havoc. And if it gets into the wrong vessels, it will just collapse the vessels. Air pressure in the lungs remain high level while pressure in the chest decreases. So again, they'll just blow up the levy. Decompression sickness, or the bends like I was talking about before. The gas and the bubbles, they get into the outside of the vascular system. And I guess it's extremely painful. And they have to go to a hyperbaric chamber. I think there's one in Portsmouth, right, Kevin? Portland, most likely. And at Dartmouth, I know there's one. So blockage of tiny blood vessels, depriving blood supply, severe pain, like especially in the joints. You find it difficult between air embolism, decompression sickness. So I guess the difference, and I don't, is air embolism occurs immediately after returning to the surface, and the bends is several hours. So there's a hyperbaric chamber. But what you're just gonna treat, bring to the local hospital, and they're gonna, unless you're down in air, wherever, down near Portsmouth, you can bring to Portsmouth. So scene safety, never dive in moving water. Never leave it up to the professionals. Never attempt a water rescue without proper training. I don't know if any EMS agency that does rescue stuff like this, but fire departments are trained for it. Let them do it. Check for additional patients. Make sure there's only one. Usually, people are supposed to dive in pairs at least. Form a general impression, sick or not sick. Is there chest pain, dyspnea, complaints, APU? Any suspicion of drug or alcohol use, because drugs or alcohol are always behind it. Make sure that the airway's open, clear, breathing. Like if they're not breathing properly, we're gonna breathe for them with a good rate. We're gonna consider spinal trauma and take appropriate actions. Suction of the patient is, of course, we're gonna clear the airway. Suction if patient is vomited. Provide ventilations. Also take monitor breath sounds. I guess it might be difficult to find a pulse. Begin CPR. Evaluate for shock and perfusion. See if there's like any cervical, if they're like dived off a boat or whatever. Make sure there's no trauma to the head or neck. If for any bleeding, gross bleeding, treat appropriately and transport to the nearest facility. Is Kevin, if you're available, is CPAP available for basics in drownings? Decompression sickness, air embolism treated with decompression. Yeah, the hyperbaric chamber. He's not here. Obtain a medical history. Do the sample history, signs and symptoms. Examine lung sounds, breath sounds. Always look for hidden threats. Air embolism. Complete detailed full body scan while en route to the hospital. Don't wait around for that. Peripheral pulses, skin color, condition, temperature, paresthesis. So that's the numbness and tingling. We're going to check for vital signs, and we're going to check for every 5 minutes. Like Kevin said before, we're not going to do really SaO2. We're going to do end tidal. That's going to be more accurate.
So the answer is yes to your question. Sorry, I can get back to you. For the EMT 2 paramedic level, you can consider CPAP to supplement the patient's own respiratory effort for drowning. So for New Hampshire, yeah, so New Hampshire protocol will be New Hampshire 4.2.
So that's probably not going to be on a quiz, but it's good to know.
No.
That's that mask. I don't know if did you pull out a CPAP mask for him?
We
Anybody?
did bring it out. We went over it like briefly. So if you want to do it again, you can.
Sure.
Yeah.
So document and talk about like time of submerge, clarity of water, possible injury, like document and let the receiving hospital know. So immobilize, protect patient's spine during diving injuries, assist ventilations in bag mask or pocket mask, provide chest compressions, like treat for hypothermia. So we did all of that with that guy that went off into the river. So for air embolism, we're gonna remove the patient from water, obviously, keep patient calm, administer oxygen, provide prompt transport, and we're gonna vital and consider possibility for pneumothorax and monitor breath sounds, because that's like if there's air in the lungs before he ascends, he doesn't breathe properly, it's gonna explode. So we're gonna check for hypothermia and breath holding for syncope. Yeah, so that whole like breathing and heart rate going down, they could have a syncopal episode. Appropriate precautions prevent most submersions and accident. Oh, yes. Any questions on that? Drowning? No. Okay. Moving along. So I can't even say that word. Dysbarism injuries. So if you ever go move along in your career, like if anybody ever goes into flight medicine, this stuff comes up. So basically, like at sea level, there's like more pressure and like more gas is more compressed because there's more pressure. But as we go up in elevations, like less pressure, that means like gases are going to be expanded and less of it. So like there's going to be theoretically more oxygen at sea level than there are much higher elevations. And so also it affects the body as well. So altitude illness, like if you ever hear about people not Mount Rushmore, but the big mountains in the middle of India,
Like Everest.
they always have to have masks.
Yeah, Everest.
Yeah, Everest. Thank you. Everest. They have to have masks in order to, or else like their brain starts dying.
Just keep in mind that the higher you go, whether you're 500,000 feet above sea level or at sea level, the percentage of oxygen never changes. It remains 21%. It's how it gets into the hemoglobin for transport. Right. So as you also extend, you got to remember something called Boyle's law, which we're not going to get into all these different altitude laws and temperature laws, but Boyle's law is like Boyle's balloon. So a patient that goes up higher, lungs will expand. Things start getting bigger. Your stomach starts to inflate more. Okay. So that's what happens with altitude. That's why they ask a lot of questions in flight medicine to find out patients' types of injuries, things like that. So then they make changes on ventilators and whatnot to make sure things don't explode. Right. Kind of a quick way, a down and dirty version of that. But there's different laws of temperature and height and altitude that like Morgan mentioned, flight medicine gets into to how this patient's going to react. But percentage of oxygen does not change. I want you guys to understand that, whether you're, like I said, 500,000 feet above sea level, whether you ever be that high, or you're at sea level itself, your percentage doesn't change, but it's how it transfers into the blood itself. Right. So there you go. I didn't want to get too in detail with it, but I don't want to have an understanding of how that kind of works in a roundabout way. You will not be tested on the laws, I promise you.
Any questions on that? No. Okay. So diminished oxygen in the air at higher altitudes. It's not diminished oxygen. It's still gonna be 21%. It's just like he said, it's complicated. So like acute mountains, like people who like go shoot up too fast and don't take breaks so that they can, their body can get used to the high altitudes. Who watches football? Which team NFL? Who's known for the Mile High Stadium, and what's one of the big Denver, right? Because of the high altitude they're supposedly at. So signs and symptoms: headache, lightheadedness, and fatigue, because there's not going to be as much oxygen passaging. Thank you. Excuse me. Acute mountain sickness signs and symptoms continue: loss of appetite, nausea, difficulty sleeping, shortness of breath, because during physical exertion, because oxygen is not going to be passing as much or easily. High altitude pulmonary edema, fluid collects in the lungs, hindering the passage. So again, like anything that complicates that, it's going to be issues. It almost looks like CHF. Shortness of breath, pink sputum, cyanosis around the lips, and rapid pulse because the body is trying to compensate. High altitude cerebral edema, so that's in the brain. May accompany HAP, life-threatening, severe constant throbbing headache. What's ataxia? A means without.
Ouch. I can't remember.
Isn't that without speaking? Extreme fatigue, vomiting, and loss of consciousness. So treatment for HAP or the HAP or ACE, provide oxygen. We're going to descend probably pretty slowly from the height to where they're able to function again. Provide ventilation, BVM, and oxygen. So we were talking about lightning earlier. This is part of it. Oh, ataxia is coordination and balance, which makes sense. Fifth most common cause of death in isolated environmental phenomenon. People who usually are outside or large openings are most likely to be struck. And I've never dealt with or seen, thank God, knock on wood, anybody who's struck by lightning. Many individuals standing near an object have been struck by lightning, such as a tree. So usually, like lightning will follow the path of least resistance to the ground. So if there's like a tree that's high, it's going to hit that first. And it does a number on the cardiovascular system, which is usually electrical, and then the nervous system. So usually can have respiratory or cardiac arrest post. Usually, sometimes like they'll go into one of the VFibs or VTACs, and we can convert them back if we're quick enough. So there's categories of injuries. Loss of consciousness, amnesia, so like they forget, confusion, tingling, then superficial burns. Like usually there's an entrance wound and an exit wound for electricity. Some moderate injuries are seizures, respiratory arrest, dysrhythmias, and superficial burns. And then severe is like a direct hit and cardiopulmonary arrest. A few weeks ago, it wasn't lightning, but somebody was working on a high power electricity, like at the nursing home around here. And I thought he thought it was like shut off. I don't know what happened. Anyways, it jolted him, and he was like hanging on to it. And so usually, like electricity will make you contract. So he counted his blessings, but there was like a clear, like he was showing me the wounds, and there was a clear entrance wound and a clear exit wound. And I told him about it. He's like, "Oh, that really makes sense," because like the entrance wounds was a lot smaller, but the exit wound was huge. So anyways, moving on. Emergency care, we're going to, again, like if we're in a lightning storm, we're going to make sure we're not carrying an umbrella. Move the patient to a sheltered area where you can work on them. I'm not sure what reverse triage is. I'm sorry for that.
It explained it in the book.
I did read.
It explained it in the book as when you triage, when you have a lot of triage patients normally, right? Don't you normally, you try and save the people that are
okay, that makes
the
sense.
best condition first, and you kind of leave the ones that you know are probably going to die. You let them die, unfortunately. I think it's opposite in lightning. I believe.
So I think
that's what they explained.
Okay, that makes sense.
Yeah.
Thank you for that.
Yeah,
I did read.
I'll look it up.
No, it makes sense. So we're going to stabilize the spine, make sure it's because I'm sure there's going to be a mechanism for the neck injury. We're going to assist the ventilations, and we're definitely going to get an AED on them as quickly as possible because the heart is functioned by electricity. So we're going to want to get that right again. If there's any bleeding, gross bleeding, we're going to control that and transport. Spider bites, and these are not the ones caused by needles. So my son was actually I don't know where it came from, but he was definitely afraid of daddy long legs. My daughter told him he was they're wicked venomous, and so it was fun. So anyways, the two big ones are the black widow. It's usually the female black widow. And I'm not sure if we have any in Maine and New Hampshire or not. And the brown recluse. I've never seen them. It doesn't mean they don't exist. But they're very bad. So that would be the black widow. They're black and they have a red hourglass on their abdomen. Oh, they are found in New Hampshire. How lovely. Every state except Alaska. Here I come. So they cause muscle spasms and localized pains and symptoms. And they're poisonous to the nerve tissue, so that they're like a nerve agent. So I guess dizziness, sweating, nausea, rashes, tightness in the chest, and severe cramps. How do we treat these? Oh, they subside within 48 hours. The patient's mostly gonna have respiratory distress, and we're gonna transport anyways to furthest closest appropriate facility, and we're probably just gonna give supportive measures. This is the bad brown recluse. They're nasty. They live in southern and central parts of the country. And they're very toxic. Whatever, if they bite something, it usually becomes necrotic, and anything that's around it will die off. For a hand or whatever. So they're venomous cytotoxic. I don't know if there's pictures. There's no pictures. I will get you guys a picture of a brown recluse bite because they're gnarly. So there's other types of stings besides bees, wasps, yellow jackets, ants. If you get enough bites of ants, that's not good. Anything that's in abundance. And wasps and bees can be, if you get stung enough, they're poisonous. Remove the stinger and use the edge of a credit card or whatever and scrape it apart, or I usually just use it like a sliver and pull it out. Anaphylaxis may occur if they're allergic. Snake bites. Do you guys have venomous snakes in Maine?
Nope.
No.
No.
You're lucky. There's only 19 in venomous in the United States. We do in New Hampshire actually. They're called mountain rattlers.
We have one town, I think, that I've read that has those. There's like one, yeah. It's like a certain area.
There are no poisonous snakes in New Hampshire. They have all moved away. Just so you know, they're all
I went to
gone.
Florida.
They're all
Are you
gone.
serious? Or are you being funny?
They don't live here. I'm gonna take that with me. If you start telling me there's poisonous snakes in New Hampshire, I'm not gonna sleep. I'm telling you, they've all moved away.
I'll let you have that. So here's 4 different types of poisonous snakes. The first is a rattler. You can tell by the rattler, and they like do the little. The copperhead, I guess those are really bad. And water moccasin's really, really bad. A coral snake. And there's a snake that looks like a coral snake, but it's not poisonous. I can't remember what it is. Snakes usually don't bite unless they're.
Don't worry about it, Morgan. Just keep going. I just
Yep.
highlighted the reverse triage so that people want to read it.
So snakes do not usually bite unless they're hungry. Oh my god, I got so many videos of snakes like attacking people. It's funny. I won't show this class. The classic American. I hate snakes too. I would never.
I do too.
So they're gonna have like 2 puncture wounds where the site is, from these lovely things right here, fangs, and then this venomous sac is right behind them. So like snakes, they like tell where they're creepy. They sense like the heat with their little tongues flickering in and out. Yeah, moving on. Rattlesnake's the most common form of pit viper. Many patterns of colored diamonds. Copperhead's usually 2 to 3 feet long. Red copper crossed with brown. So yeah, you saw the. Go back. The copper, and then there's like the little. I have no idea what that is. They're gross. We're moving on. So venom, severe burning, swelling. Depends on what kind of snake it is. I do not suggest bringing those to the ER. If don't,
No.
So vision problems probably could have altered mental status and end up in shock. Treatment. I don't know how you're ever going to calm a patient down unless they're like a snake handler or whatever, because I would be not happy. Give me some Versed. Transport in a supine position. Locate the snake bite and clean it gently with soap and water. Treat for anaphylaxis. Don't give anything by mouth, and be alert for vomiting. So treat if the bite occurred next to or in the trunk, from here to here. Where do we go? Keep it in a supine position and quiet, and transport it quickly as possible. Well, we're gonna shock anyway. Fuck that. If the snake has been killed, bring it with you. Nope.
Take a picture of it. Take a picture.
Yep. I'm gonna do that. I will probably not get close enough. Notify the hospital that you're bringing with a snake bite that you're bringing. Of course, we're gonna rate it. Not doing it. Coral snakes, I guess. Yellow black bands completely encircling the body. They live in southern New Hampshire, or not New Hampshire. Excuse me. There's no venomous snakes in New Hampshire. They live in the southern United States. Apparently, they have tiny fangs and they do a chewing motion. Right? Bizarre behavior, also neurological. Progressive paralysis and eye movement and respiration. Emergency care is the same as for a pit viper. Stay away. Any questions on snake bites?
Nope.
I bet you're gonna see it. We do not constrict, and we do. I know they talked about it, like putting like a cold pack over the wounds, but we don't constrict. Scorpions, 8-legged arachnoids, and they have a little stinger on their tail. They're quite abundant in the southern west. I don't know what the book is talking about. They're painful but not dangerous. There's a little guy. So they can cause circulatory collapse, severe muscle contractions, salivation, hypertension, and cardiac failure, convulsions. Any questions on scorpions? Usually not fatal, but they could be fatal. Tick bites usually attach themselves directly to the skin. We do have these in New Hampshire. The little ones are.
I said I hate those little suckers.
Oh, I know.
Ticks are
They are prominent with Lyme disease. So they're really tiny. And so there's like a bullseye, what's called a bullseye pattern for where they bite. And that's what didn't somebody like talk about getting Lyme disease or had Lyme disease?
Yeah, Tina.
Tina did.
Tina had
Yeah,
it,
that's really bad. Rocky Mountain fever, spotted fever occurs 7 to 10 days. Again, with all the general everything else, nausea, vomiting, headache, weakness, paralysis, and cardiorespiratory collapse. Reported in all states except for Hawaii. There were no snakes in Hawaii at one point, but we brought them there. We introduced them. Fun fact. The fever, flu-like symptoms, body aches, especially at the joints, bullseye rash, several parts of the body. Painful swelling at the joints, may be confused with rheumatoid arthritis. And I think it's a lot of antibiotics to cure that, if it's ever.
It is, yeah.
The tick bites occur most commonly during the summer months, when they're most prominent, and deer like to transport them as well as moose. Use fine tweezers to pull out. Make sure you get the head, because that's what, like, when they regurgitate is when they start to, like, when they latch on, it's not bad, but when after they fill up on your blood and they regurgitate it back in, that's when the issues start happening. Once the ticker is removed, of course, soap and water. Any questions on that? No, we're all familiar with tick bites.
Yeah.
So this always reminds me of Steve Irwin because I'm a sick person.
Poor bastard.
So
How many crocodiles did he play with?
Yeah, and a fucking what is it called? I don't know.
A Man of War, or was it?
A Man of War.
Stingray.
Stingray, the barb.
Yeah, right to the heart.
Right. Just right.
So I took my daughter, and I know we're really running late. I took my daughter to an aquarium once, and they had those things, and they're like, yeah, they're really docile, and they're no mortality rates. And I'm like, yeah, tell that to Steve Irwin. And she just kind of looked at me.
Crikey.
So
yeah.
So jellyfish are really bad for bites, venom. So signs and symptoms of red lesions, cramps, dizziness, fainting, light-skinned individuals. Avoid fishing or keep the patient calm, reduce motion of the affected area. Remove the tentacles by scraping them off with edges of a sharp, stiff object. Transport. Any questions?
Nope.
Let's just, you want to do the review real quick?
Test.
Yeah, do the review.
Okay. When a person is exposed to cold temperatures and strong winds for an extended period of time, he or she will lose heat mostly by
B.
I would go with B.
Convection. Yes, that's the air.
Right,
Yep.
Air. Shivering in the presence of hypothermic patient indicates that the muscle system is damaged. Nerve endings are damaged, causing a loss of muscle control. Body is trying to generate more heat through muscle activity. Thermoregulatory system has failed. Body temperature is falling.
C.
Yep, we're trying to create. All the following are examples of passive rewarming techniques except remove cold, wet clothing, Administer warm fluid by mouth, which turning up the heat inside the ambulance or covering the patient with blankets, warm blankets. Passively
I
warming.
would say B.
Probably would go with B too. Yep.
Because didn't you say something about giving them flu? Like, what if they needed medical? You wouldn't want to give them anything by mouth
Right. If they need surgery.
or something.
Surgery.
Yeah.
A woman has frostbite in both feet after walking several miles in a frozen field. Her feet were white, hard, and cold to the touch. Treatment at the scene should be rubbing her feet gently
No.
and next to a warm fire. Reading.
Trying to source it up.
No,
No.
Trying to restore circulation by helping her walk around. That's not going to work. Remove her wet clothing, rubbing her feet. No, that's not going to work. Remove her
No.
wet clothing, covering
D.
your feet with dry, sterile
D.
dressing. The only one
D.
that-
D's and dog.
A 30-year-old male who has been
Uh-oh. Hey.
Playing softball in a hot environment complains of weakness and after experiencing symptoms.
and there's no beer involved. Right.
Apparently, treatment for this patient includes all of the following.
Except
Set.
Want to move her.
Yep. You want to do oxygen. Place them in the supine. I guess it would. I mean, we know the answer is A, but
A.
yeah, we never give them nothing by mouth, especially salt-containing solution.
right.
I bet you did in the army though, didn't you, Jason?
Yeah. Pedialyte's awesome. They sell it now. Like adult
Oh, I know,
Pedialyte
for
or like
everything.
a Gatorade Pedialyte. It's really cool stuff.
Later, like.
We don't. You're
Yes.
assessing a 27-year-old woman with heat-related emergency. Her skin is flushed, hot, and moist. Her level of consciousness decreased. After moving her to a cool environment, you're managing her airway and administering oxygen. You should A, give her ice water. B, a recovery position. C, cover her with wet sheets and fan, and take her temperature with an auxiliary probe.
I'm gonna say D.
Probably D.
I would rather do C.
Right, but D. I think
Oh.
is. Oh,
Oh!
Jason.
Cover her
Wow.
with a sweat sheet. Begin fanning her chemical ice packs to groin axilla.
Jason.
I don't know. Maybe. I don't know about wet, but sure. But yeah, the moist
What's to say?
moist fan. It is important to remove drowning victim from the water before lymphospasm relaxes because the patient will suffer less airway trauma. The risk of severe hypothermia is lessened. Less water will have entered the patient's lungs. It will be that. You can ventilate a patient with a lymphospasm.
C.
C. You say C or D?
I think it's C, Charlie.
Yeah.
C. Oh no. A 13-year-old girl is found floating face down in a swimming pool. Witnesses tell you that the girl had been practicing diving. After you and your partner safely entered the water, you should A, turn her head to the side and give her 5 back slaps.
Oh yeah.
Turn her head to the side and begin rescue breathing. Rotate her body as a unit. Carefully remove her from the pool. Rotate her upper body as a unit and supporting her head and neck.
This
D.
is a tough one.
D.
I would say D.
D.
Because you can't. There's no point doing her airway if she's broken her neck.
It's D.
Yes.
Rotate her. C was rotate her entire body as a unit.
Yeah, but
Right,
D
you
was
really,
rotate the entire
Water.
upper half of her
see,
body.
this
But
is where.
remember,
Yeah, go ahead, Jen.
well, I was going to say he read the slide where it said we always support them in the water before we move them out of the water. So we would need to.
Yeah.
We're supporting her, and her upper body as her spine would be her head before we remove her from
Yeah,
the water.
and you're not really worried about her feet. Yeah, true. All right. Yep. Supporting her head and neck is a big one, so I should.
At least that's my answer. I don't know if it's right,
Yep,
but
D's
that's-
right.
Yeah. Basically.
Okay.
When caring for a patient who is in the water, possibly been injured, rotate upper half of the body's unit supporting the head and jaw.
Yeah.
Tell the patient's face up, open airway, jaw thrust maneuver, begin artificial ventilations. Yeah. So we care really about the head and airway.
Right.
Yeah.
Shortly after ascending rapidly to the surface of the water while holding his breath, a 29-year-old diver begins coughing up pink frothy sputum and complains of dyspnea and chest pain. You should suspect and treat this patient for air embolism, pneumothorax, a pneumomediastinum, and decompression sickness.
D.
Who said D?
I think it's A. Isn't that the pink frothy sputum he was talking about?
I think it might be B.
Could be B.
No.
Maybe A.
Well, it could be B because he was holdling his
I'll be the
breath.
tiebreaker. A.
Colin, oh, Clay.
Ed.
Clay's the, or no, it's Colin. I forget.
Colin.
Colin.
Yeah. Oh,
Sorry. Yeah, because there's also another keyword in here while holding his breath 20 rings covenant. So I think it said rapidly, like shortly after. And that was one of the keywords between A and D. Is like, yeah, decompression sickness takes a long time. Air embolisms almost immediately. But it also could be a pneumothorax because he was holding his breath, and so that pressure is going to expand and could cause a pneumo. So where are we? Let's see. It's A.
Oh, good job.
Yay. Yay.
Rapidus. So that's when the air like kind of moves out of the lungs into the bloodstream itself. 3 ambulances respond to a golf course where 6 golfers were struck by lightning.
Oh, shit.
Oh, this is the reverse thing, isn't it? The 2 golfers are conscious and alert with superficial skin burns. Next 2 golfers have minor fractures and appear confused. The last 2 golfers are cardiac arrest. According to the reverse triage, which group of golfers should be treated first?
3.
3. Yep.
3.
Thanks to Jason. Oh my God. It's late. Sorry.
Cool. No problem. 6
I
o'clock
don't know if,
Thursday.
yes.
Oh,
I don't know
don't
if
forget, we
Kevin's
get
still on,
that.
if he has anything for you.
We get that.
I'm still here. I'm
capnography
taking your quiz.
stuff tomorrow night.
Mhm.
Kevin, that capnography's tomorrow night, right?
Correct,
Yeah.
at 6.
6. Maybe.
I
Yeah.
won't be. I don't think I'll be there if I can get on in time because I'll be in Berlin tomorrow with Eric and whoever else is there. Morgan, are you there tomorrow?
No.
I'm going to record it as well.
Okay, good.
Oh, then I might miss it because I got to read tomorrow night. So I think I might miss it.
But it's a good chance for people to take it.
Yeah.
Then they can ask questions live about it.
Right.
Oh, all right.
But
I mean,
it's
I
up to
can
you.
tune in on my phone. If we get a call, then we get a call. But
That's fine.
Who's there tomorrow? There's a computer up front you can use.
Just remember, this is not a required class. It's just, it'd be good
Yeah.
information.
It is.
Yeah.
Yep. Agree.
But
All right. We all set?
I mean, I'm good. Just for those of
Thank
you who
you.
haven't gotten all your paperwork in, you're running out of time. So let's get the stuff in and get your clinical time done. Get your contacts.
you,
Yeah,
you got
I've got all
my,
mine.
you got my medical thing, right? I emailed that to you.
Yes.
Okay, cool.
Just make sure you guys are doing your run reports every patient contact.
Yeah, I've only had 1 patient so far.
Yeah, Tina had a good day. So
Yeah, she had a really good day today. She's not why she's here. She's going to Maine Med on another transfer.
yeah, she actually had a STEMI the other day. So. All right, well, that's all I had for you guys tonight. I mean, it's kind of late. It's 10:30, so I do appreciate you guys hanging out this long.
Okay, thank you.
But we'll definitely talk more Thursday.
I guess.
Night.
Thanks,
All right,
Morgan.
good night,
Bye.
everyone.
Night. Bye, guys.
Bye.